Hello everybody, this is Ursula James from the IAP National Programme. Thank you for joining our webinar today, which is focusing on PWP interventions delivered remotely. I'd firstly like to say a huge thank you to colleagues from Buckinghamshire and from Exeter University. So we have a number of colleagues from the Buckinghamshire service and Paul Farrand from the Exeter University who've spent time providing the slides and setting this up for today. So huge thank you to them. Your lines are automatically muted when you join the webinar. So if you could use the chat function throughout the webinar to ask questions and provide any comments or input. What we'll do is we'll try to answer as many of those questions as we can during the webinar, but there will be some time to put the most liked questions to the presenters at the end of the webinar. So you can thumbs up each of the questions as a way for us to know which ones to prioritise. The webinar is being recorded and we will share the recording download links together with the slides after the webinar to those of you who are on our contact list and who've received the invite directly from the national team. I'm afraid we don't provide any CPD certificates for attendance and there will be no FAQ. But thank you for joining us today, and I will hand over to Paul from Exeter University.
Well, hello everyone. I don't know how many of you are used to this format. It's certainly a new one on me, so hopefully I'll adapt to it very quickly. As Ursula said, what we're going to focus on today is delivering safe PWP interventions by remote working. And I'm going to do the first part, and colleagues from Healthy Mind Bucks are going to do the second part. Okay, Sarah, is that okay? So the aims of the webinar really is I'm going to take the first bullet point there and understanding remote training and working over the telephone, really to identify how it maintains safe and competent practice. I don't think we can talk about safety of remote delivery, or indeed delivery full stop, unless we also talk about the role that training has. And indeed training is likely to be at least amended, given that it has to also be delivered remotely also. And then the colleagues from Healthy Mind Bucks are going to talk about how the more clinically facing direct stuff, supporting people remotely at step 2, and then also supporting PWPs working remotely. Okay, Sam. So in terms of my part of the talk, I'm going to overview the current curriculum requirements as a result of the BPS adaptations to accommodate limitations. Obviously, we can't do things the way we have been doing due to limitations of COVID, so that requires remote delivery. And I will go through the BPS requirements, but then what I want to do is to highlight and reassure people, whilst it's becoming remote, actually the safety is being maintained at all times, and the things are being maintained that IAPT is being built on, such as competency, evidence-based practice. On the basis of evidence-based, I will also discuss remote learning, but consider it from an evidence-based supporting potentially what will be done in at least the short term and maybe the longer term. As scientists, practitioners, we should always be aware of the evidence base, and there's indeed an evidence base about best practice regarding training as well. And I'm going to highlight the application of the declarative procedural reflective model from James Bennett Levy to highlight how this clinical model can actually be used and implemented to really structure a remote learning approach, because it fits incredibly well. Okay. Right. In response to COVID, the BPS have published guidance on what's acceptable adaptations to training. And because IAPT has always been built on this implementation model, where things get implemented through training, and then the BPS ensure the accreditation of that training to ensure that services don't go off-piste unnecessarily, the BPS have come up with the following recommendations. First of all, that services should consider trainees have completed the programme where 75% of the current 80 clinical contact hours are met. So they're building in the fact that some services may struggle to get up and running in time, and we don't want that to impact too much and hopefully on trainees. So what they're suggesting is that there can be a reduction for people to complete the training, but to maintain the safety through training, the remaining hours have to be met within 3 months of course completion. So trainees won't be held up. They can still complete the actual taught part of training, but for safety's sake, they need to still complete the extra 80 hours within 3 months. 3 months is also required to submit a live competency tape. In the curriculum, module 2 is a support session with a live patient. Once again, there may be some challenges getting the live patient tape. So for the training purposes, it's okay to use a simulation, as indeed the original curriculum used to use. However, they have to have that live patient tape 3 months after the end of training again. Obviously, a lot of this presentation is about remote learning, and they're talking about BPS greater consideration to gaining your patient contact hours and your supervision hours through other means, other modalities, whether that be the video conference, the telephone, or other text-based approaches. And there's consideration for gaining supervision hours in other ways. So the requirements for the supervision hours, there's one possibility about gaining some of the clinical skills hours through the training providers. And once again, going remote and using a different way of delivering may facilitate this process. As I mentioned, the fidelity to the curriculum content is rigorously managed by the BPS, very, very rigorously. I sit on the committee that ensures and gives oversight. And the reason why this is so important is simply because clinical practice itself can only be safe when the accredited curriculum is adhered to. We can talk about innovations in practice and delivery, but if we don't have the accredited curriculum and ensure that the BPS maintain what's in the content, then we can't actually say that PWPs, high intensity, or anyone is actually delivering in a safe and competent manner. That's one of the benefits of the IAP programme. Okay. So if we start thinking about current remote training delivery, remote training has quite a history in CBT and more generally. And the significant research in remote delivery and training has been extensively covered by James Bennett-Levy. And he talked about something which called the first generation of CBT training. And this was predominantly where a lot of the content was delivered online. So we had the OCTC groundbreaking program, we had Praxis CBT. Predominantly the focus was on a theoretical basis, delivering the theoretical material, and some skill simulation, with the skill simulations coming through online videos. And supervision was actually seen as the main way to enhance the competency development. But one of the observations from James Bennett-Levy was it's not structured as a systematic training programme. As we know from the evidence and what's going to be proposed during COVID restrictions, is we have to think far more about a training programme which builds on separate elements of delivery rather than just a predominant online delivery supplemented in a non-systematic way. Oh, can we move the slide? So there is evidence, not specific to clinical training, about the benefits of remote training for us all. Actually, I think there are potential. COVID is going to open lots of opportunities and potentially opportunities to make things done better from a training perspective. liaising and interacting far more with services as well. One of the interesting areas and observations is the delivery format simply as a carrier of content. There's no impact on ability to learn. And interestingly, this overlaps with what we know clinically, in that you can deliver a lot of clinical content through step 2 through CBT self-help materials, but it's not impacting on effectiveness. So there's some parallels. But what there needs to be is there needs to be consideration of the way and the match between the training modality and the way in which you're using the right method to deliver that modality of training. And now, once again, that parallels to clinical practice. So we know in terms of clinical practice, there has to be some interactive engagement and support. The evidence base at step 2 is for supported, guided self-help, not just unguided, self-administered. So what we know actually is, however, remote approaches promote and enhance clinical training, but actually only in addition to other training approaches. Just moving stuff online isn't enough. We need to complement and supplement it. Can I have the next slide, please? Oh, this isn't a good sign, is it? So the supplementation of the training is through blended learning. And what we know is training is optimized where remote and face-to-face approaches are seen as complementary. But I would say face-to-face doesn't have to be in a classroom. It can be face-to-face through remote learning, through online devices. James Bennett-Levy talked about a systematic model of delivery in terms of declarative, procedural and reflective. Declarative being the theoretical knowledge and the conceptual understanding. And he saw that as modelling the bridge between declarative procedural. So declarative informed the procedural. The procedural skills development is very much around competency, and very much the requirement is around role play and supervision around live patient work. And this is one of the requirements, that there is a big skills-based focus in the training. It can't just be declarative online delivery. And then there's the reflective, whether it's the consolidation of skills, learning and arising from practice through reflection. OK, can we move on to the next one? So let's look at evidence to inform a more blended learning and ensure safety in what the training, what the practitioners and the therapists actually do. Firstly, we've got online delivery of declarative content actually is beneficial because it gives trainees greater control over the way they engage with the materials, and it has benefits to assessment. It's identified that when you have online delivery of declarative content, people tend to do better in terms of their understanding about the conceptual. Partly because actually if you're delivering online some of the declarative content, people are able to engage with that material at a better time that to suit them. So they can revisit the material as well if they lack understanding. And also they're able to shift their training engagement around other demands they may have, which can actually help to improve access into training. Online simulations, this is where you may do a recorded assessment, a pre-recorded assessment, often from a clinician, has modest benefits over declarative only. So it's beneficial to have online pre-recorded sections, but actually they're only modest over description. What is required is that interactive element, which we'll look at under procedural. We also know that outcomes are better if you have the interactivity. It builds knowledge and it supports the application of knowledge. So having individualization by having the ability to ask questions, such as the way the webinars are set up, can actually enhance standard delivery as well. Can we move on? So we know, as I've mentioned, we need experiential techniques to translate declarative procedural. You can't get around it, and the BPS ensure that that's a fundamental part of the IAPT curriculum. What we also know is the effectiveness of training and competency is enhanced where with role play and supervision core components. So these have to be maintained. If we go remote, we can't just go remote and at the extent. This is such a new experience. I'm losing my head. We can't actually just forget about the competency based. And what we also know is if you have that competency based focus, you have higher self-reported confidence in clinical skills and practice. We know that there are barriers to the use of telephone when the training isn't competency based around the telephone. So we'll look at that a bit later in terms of one of the barriers to the adoption of telephone, because part of that is down to the trainers. And also we know that live skills practice with feedback is the best approach within training to enhance competency development. So that has to maintain very much a core feature. Could we move on? And also the role of reflective practice. It's fundamental that training should both promote reflection and actually there has to be a role of reflection in terms of the delivery of training. And partly this can be done through workshops. So online workshops, virtual workshops, which are based around reflective groups. That promotes also the interactivity. So people are more likely to carry on remaining engaged with training, but it also suggests a role for reflection. Can we move? So let's think how we achieve, just as we're doing now, actually, the evolution of web-based technology are supporting remote training. They're supporting these webinars by providing a platform through which to present this blended learning model. So declarative can go in terms of text, put learning materials online, video demonstrations like we've discussed from a practitioner, from a member of a training team, through audio support, but then it can also support real-time competency development. So we can support, because we're doing this already, people role-playing over the technology and then giving feedback. So rather than having to be face-to-face and give it feedback in the room, we can do the same using technologies. And then breakout rooms. A lot of these technologies support breakout rooms where we can support reflection or the discussion of declarative information. And that's the way to enhance the interactivity. And through those mechanisms, that's the way to keep the training safe, even with these new technologies. Can we move to the next slide, please? Also, given potential changes in the way the training is going to be both commissioned and delivered, we can set up virtual communities of practice. So in these virtual communities of practice, this is where a bridge between the trainer, the trainee, and the service can be created. What can happen is you could have clinical skills between these three groups. We could clarify any misunderstanding, and it begins to close what is the current gap between the service and the trainer for the mutual benefit of all. It can also promote self-care, and I know a bit later on they're going to be talking about how self-care of PWPs and other clinicians can be enhanced through remote delivery. And one way in which this is going to enhance is certainly around the apprenticeship training. And I know Healthy Mind Bucks are the first group to go to the apprenticeship training, and they're going to be mentioning this a bit later on. So remote training actually potentially offers a better bridge, which can then once again increase the safety. Are we okay to move through? So that's really the end of the training, and I hope I've got it expressed enough how remote training won't reduce the safety. In fact, a lot of the evidence suggests it will increase the quality and will increase access to underrepresented groups who may otherwise have problems attending the training. What I'd like to move on now is about the telephone to support low intensity CBT as a remote way of delivering training. And I'm going to overview the role of the telephone in the clinical method, because it's been there from day one. highlight the extensive evidence-based. It's incredibly highly evidence-based, both in terms of effectiveness and acceptability, and also the evidence-base covers step 2 and also step 3 in terms of some of Karina's work with OCD. Recognise the barriers to implementation and then also look at how we adapt clinical practice to accommodate the telephone and maintain that safety. We okay to move? So what we should always remember is an aim of the IAP programme is to improve access. And the telephone has featured since day one of the IAP programme, quite rightly given its evidence base, given the acceptability. So it's always been there as one way to improve access. It's especially important because most people have a phone and it's highly familiar to use. So it's a technology that people can readily engage with, and it's a technology that's very easily accessed by a lot of people, actually from a lot of different locations as well. But what we shouldn't, sometimes the phone is only pitched and it's only seen as a benefit for the for potentially older people. We shouldn't dismiss also the benefits of computer-based support for older people. If we look at the Office for National Statistics data, the computers are being massively used in every cohort, increasingly more. So communication between 65 to 74-year-olds, 76% of people in those age groups use computers. 63, 75% above for communication purposes, and general surfing and browsing, 65 to 74, 65%, 75 years and older, 71%. So we're already seeing a large number of older people using computers. So it should be an option, a choice, but it shouldn't be at the expense of the telephone. Can we move on, please? So let's look at the evidence on the effectiveness of telephone. There's a systematic review done by Penny B up in Manchester, and she looked at 10 telephone studies. Panic agoraphobia versus no treatment. Telephone was better than no treatment. Depression, it was superior to usual care. Most interestingly, a study was done 39,000 adults treated in IAP for mild to moderate mental health difficulties, and there were no differences between face-to-face and telephone. The only actual difference was telephone was 36% less expensive per session to deliver. So we can see the real gains. We shouldn't forget video conference here, in that there has been a systematic review done on video conferencing back in 2015. However, these studies are generally non-definitive. They don't suggest that there's anything wrong with using video conferencing, but most of these studies are individual case studies or a case series. They haven't got the same evidence base, randomized controlled trials, etc., that the telephone has. So there's nothing holding you back, but the evidence isn't there to fully support this way of working currently. So can we move on? Let's look at acceptability, because we'll notice a bit later on that a lot of people are talking about barriers, because a lot of barriers are presumed to be the case that patients won't like working over the telephone. Once again, Penny B has done a lot of evidence around the telephone and some of the evidence about why it's acceptable. Patients like it because it's easier to maintain confidentiality. They have an issue if they're having to enter a mental health service for face-to-face, but this is one way to reduce those elements about perceived stigma, etc. It improves access because it reduces travelling times, travel demands. You can organise it around your work or your life, and treatment actually can be provided even when the patient moves. I'm the student wellbeing lead at the university, and one of the benefits of the telephone is that students can receive treatment at a distance. So it stops the student wellbeing services closing down during holiday periods. Video conferencing, there's no significant differences in patient satisfaction or therapist rating of the working alliance either. So we see actually no difference once again between face-to-face or the telephone working, between face-to-face, telephone or video conferencing. Okay, can we move on? Now let's look at why then, given everything I'm saying, the extensive benefit around the telephone, why isn't it used more regularly? What is the barrier? Well, what we know is actually some of the barriers tend to be around staff, senior staff attitudes towards using towards using the telephone. People may not like the thought of using the telephone themselves, so they don't look to readily implement or actually encourage use amongst their staff. As we said, there is the evidence base, the evidence and shows patients find it acceptable. So this is a bit of an uncertainty as to what's going on. Some senior people actually want to work face to face, but if we think about the opportunity cost, we saw massive cost savings with telephone use. So we have to think about the cost. If we just use face to face, actually that's bringing resources from other places. There's a perception that the therapeutic alliance and engagement cannot be established because of lack of visual cues. Well, there's ways to work safely over the telephone which supplement and complement the visual cues that you may rely on if you're working face to face. Some people suggest that the essence of therapy has gone. Once again, this comes down to the attitudes or beliefs of the people who are holding these views. Doing things on the cheap, this is a kickback to the whole notion of the telephone. I would be completely opposed to the idea of using the telephone simply because it was cheap. But I'm actually all for using the telephone if satisfaction and acceptability is just as high, but that money and the costs that are saved can be pushed elsewhere. And then the barriers of poor training and risk. Can we move on to the next slide? So what we know about poor training, and Penny B has picked up on this very nicely, is where PWPs don't consider themselves as having enough confidence and they consider the training poor, was where the training provider was purely focused on declarative understanding about how the telephone could be used without the competency development aspect of training. So they don't do the simulated role play back to back as you may do if you were doing face to face in the room and then giving feedback directly. These courses are just basically delivering declarative content. This shouldn't be happening because competency-based training for face-to-face and over the telephone has always been stressed in the original curriculum. So what I would suggest is contact your training providers if there's reluctance from your PWPs to work over the telephone because they don't consider themselves confident. That should come and arise from the training. So it would be good to get to the bottom of that for safe and effective practice. Can we move on? Risk. Some people have concerns over risk over the telephone. The idea that you can't manage, say in a safe way, you can't manage risk across the telephone. Well, what we should always remember is actually the Samaritans do this on a daily basis, and they've done it since 1953. And they deal with all types of risk, including very high levels of risk at times. So if we consider the Samaritans as a good route around risk, then it's a bit surprising that some people have an opposition to using it within IAP services. And indeed, it's done within universities routinely. At the University of Exeter, they have a student-led nightline service for students who are feeling risky during the evening. What Penny B suggests, though, is what we therefore need is the service to take responsibility to ensure that they clarify the use and the reach of the telephone. They have clear and explicit information governance around the telephone, and the risk protocols for the telephone are very clear as well to all concerned. So if at a service level there are concerns, it should be for the service itself to start thinking about whether their service protocols address all the areas to ensure safe practice over the telephone. Could we move on, please? Risk and safety. One thing about safety in the PWP workforce is around the role of case management supervision. They ensure safety and it's built into the system. Once again, though, we need a rigorous focus on the training, because the training is fundamental to competency around the use of the telephone, and indeed wider. Other professionals have highlighted how rigorous step 2 working is around risk and safety over the telephone. So we've got some good triangulation of evidence there as well. If we could move on. So if we think about the adaptations to the clinical method, one thing is choice has to remain essential. One of the IAPT improving access is fundamental is about choice. So it should remain fundamental that the telephone is offered alongside any other modalities of support. We need to establish when working over the telephone that the PWP has the personal competency and it's acceptable to patients to do it. They should highlight ways in which the approaches work. The conventional therapy model that people have in their head is face-to-face. So if you talk about any other methods of delivery, it's going to seem highly unusual. And there's a good quote that familiarity can or should no longer be a necessary condition for trust, but we've got to educate the patients in that, and also establishing the patient's perceptions and attitudes to understand any barriers the patients may have themselves. If we could move on. Preparation is core to the to working over the telephone. So recognising pauses, in educating the students around the patients around the pauses and how to manage them, and ensuring the patient telephone. We are okay to move? Next slide, please. Organisation around the practitioner and the patient. Do what you can in advance of the session, such as completing the minimum data set in advance of the session, so you don't have to waste time doing it during the session. Asking the patient to very clearly highlight any challenges they've had before they come to discussing being supported, so they're able to articulate it better. And also highlight very clearly page numbers, worksheets, etc. So the PWP and the patient can actually engage very quickly in the support session. Okay, next slide. Don't forget the common factor skills. I won't list them out, but the common factor skills, one, enhance the way in which you can work over the telephone. In fact, they're probably more important over the telephone, but they are a fundamental feature of the training. Next slide, please. So key messages. Clinical practice is actually only safe when it's an accredited curriculum is adhered to. If we start drifting too far away from the accredited curriculum, training delivery may start becoming unsafe if we do it remotely. The training adaptations are going to be reviewed by Adrian and his team leading around the education and training. So whilst the suggestions I've made are very much dealing with adaptations now, things may change again into the future when they've been reviewed. Asking PWPs to work in a way where competency has not been developed through training is the main challenge to safe practice. So we have to maintain this link to the training to ensure safe practice. Telephone is a recognised technology. The acceptability is high, so let's not actually exclude it from a service perspective. Let the patient decide. If you don't feel that the PWPs or they report not feeling confident working over the telephone or with risk management protocols, go back to your training provider. This is what they get paid for. It should be being covered. So have this discussion about what's going on. We've talked about the benefits of telephone working, the evidence base, large evidence base, and also the acceptability. So reflect on reasons where opposition may occur within the service. And finally, a call out for step 2 working. PWPs have a very long history of remote working. They represent your implementation leaders. If you actually start promoting them within roles, potentially we can really take forward at a pace remote learning from the PWPs who are trained from the outset in this way of working. Okay, next slide, please. Thanks for your attention. I can see messages flying up. I'll be handing over to my colleagues now from Healthy Minds Bucks, who will take forward some of these conversations from their perspective. So thank you very much.
Thank you, Paul. So I'm John Pym. I'm the clinical lead for the Buckinghamshire Healthy Minds service, and hopefully we can see the first slide coming up. And I'm going to be joined by my colleagues Alex, Sarah and Tanya, who are going to be illustrating some of the things we want to show you. So the sections we're going to look at, we're going to talk a little bit about what you could be doing to actively promote IAP services to show that they're open and available and could be very helpful at this time. And then we're going to talk a bit about remote practice for PWPs, in particular, how you can offer a choice of different types of remote intervention, how those interventions can be made to be safe and accessible, and also how we can adapt our practice to ensure that they are effective. So we'll go on to the next slide. So a few weeks ago, when we first started to face the problems around the COVID pandemic, we got together across Oxford Health Trust, where we have 2 IAP services, and met with our colleagues and thought, what could we be doing to try to offer more to people at this time in terms of the types of needs that they might experience as we go through the pandemic. And first thing we did was to think, actually, could we modify some of our website to include materials that might be useful to people and draw people towards the IAP services for support and help. So we took a stage of redesigning our front pages of our websites, making new videos and making new materials to address the particular needs that we thought people might have at this time. So we've gone to the next slide. It's focused really on making short video clips for people, kind of 3 to 6 minutes, around 3 major areas around anxiety, social isolation, and maintaining your well-being. And through those different video clips, what we hope to do was give people a little bit of digestible information, but also some tips and ways they could do it. And we'll show a little bit of the video now, Sarah, if we can.
In this time of uncertainty and upheaval, we know that we can experience challenges to our mental health as well as our physical health. In this video, we're going to run through some tips on how to manage your well-being during the coronavirus situation. We know that there are 5 different ways to manage our well-being. These are connecting to other people, keeping active, taking notice, learning, and giving. We're going to run through each of these in turn to think about how you can incorporate them to manage your own well-being. The first area I'm going to talk about.
Thank you very much. You can watch the rest of the video clips. If you've got into that and thought, oh, what's she going to say next? You can watch that on our website along with the other videos. And if people have become a bit interested in that, we'll hope they'll go on and click onto a new video we've created, which explains more about what IAP can offer and the process that we go through for an assessment. And that naturally flows onto them then clicking onto the button to make a self-referral into our service. Next slide. So once somebody has clicked on that self-referral button, or phoned us or texted us to get into the service, they'd be offered a brief screening assessment. And traditionally, we've done most of these over the telephone anyway, but we have thought about how to adapt them in this situation. We've particularly thought about adapting some of the administrative procedures so that we can send people emails of letters and information. We've moved all our staff to being able to use Document so that the letters they send to GPs will go automatically into the GP systems. We've also encouraged people to use the online portal for collecting the minimum data set. Next, we've thought carefully about the questions we were asking in our assessment and whether there might be additional questions or ideas that we'd want to ask around the COVID situation. So we're picking up things like social needs. Have they changed? If people are isolated, can they get access to the kind of practical things they need? And also, in terms of safeguarding, looking at issues about are there risks for that person because of the situation they're in. And finally, thinking with them about, do they have the technology available to them? So what kinds of interventions might we be able to offer them, and how could we help them to access them? So I'm going to hand over to my colleague Alex now, who's going to tell us a little bit more about those interventions.
Hopefully everyone can see me now. John said, my name is Alex. I'm a PWP, and one of my roles involves working as part of the digital team at Healthy Minds. Today I'm briefly going to talk through how at Healthy Minds we've continued to offer both CCBT and telephone guided self-help remotely, whilst also introducing a new mode of delivery, which is video guided self-help. And I'm also going to cover what adaptations we've made to be able to offer this remotely. If you come to the next slide, please. So CCBT. So one of the interventions that required the least adaptations to facilitate from home was CCBT, or computerized cognitive behavioral therapy, delivering CBT-based techniques and interventions online through use of a program such as SilverCloud. There are two ways in which we can continue to offer CCBT remotely. So we continue to traditionally offer it as a guided light touch intervention, whereby the clients go through the program by themselves, but have weekly online reviews with the clinician. But we're also, SilverCloud has now offered us an unlimited license. So what this means as a service is that we're able to use CCBT as a pure self-help intervention as well. So with the client just working through this without the clinician. The potential for this going forward means that we can use CCBT more widely, and even going ahead, we can use it to supplement other interventions or perhaps provide further support for people whilst they're on waiting lists. Also, the provider that we use, SilverCloud, has also developed a COVID-19 orientated module. And this module just basically looks at providing mental health support for anyone at the moment who's dealing with difficult emotions, situations brought on by COVID-19. So this can include frontline staff, parents, people providing essential services, and people in self-isolation. So CCBT is an intervention that we'll be able to continue to offer remotely. Secondly, next we've got the telephone guided self-help. So that's also something that we've been able to offer and continue to offer remotely, and it remains an excellent way to offer guided self-help, as discussed in Paul's research. We've adapted it by moving to using mobile phones at home, and we've also used and ordered headphones for staff so they can continue to do telephone assessments and treatments at home, but in a confidential way. So like CCBT, we've not had to make too many alterations or adaptations to be able to continue to deliver telephone guided self-help from home. If I could go to the next slide, please. So working with interpreters is something which we've also been able to continue to do remotely. So our interpreting service can be booked in for telephone sessions. As clinicians, what we do is we contact the service 10 minutes prior to the appointment, and we just request the language that we require for the session. We then put on hold until an interpreter has been found, and then we're able to conference them in to the session. Interpreters can also be booked in advance if needed. So in the past, I've worked with dialects which are a little bit hard to find, so I've called up the service a week in advance, booked in with an interpreter with a specific language I need, so we are able to look in advance as well. And just to add, more recently, British Sign Language interpreters have now been able to offer their interpreting services for using video calls as well. So that might be something services would like to look into. In terms of using interpreters from home, we did initially experience some challenges. For example, with most of us using work mobiles with reduced functionality in comparison to landlines would usually use at work, we weren't able to conference call both clients and interpreters in on our end, and it was an issue highlighted by one of our colleagues with an email sent to the digital team. So the way that we managed this was by ensuring that we could request the interpreter themselves conferences the client in to the call for us, thereby kind of circumventing that limitation. And it's a good example of why kind of open communication between colleagues is crucial, especially when working remotely and when having to make adaptations. And just to add, a further way in which we could develop our use of interpreting services is to begin to use these in our video consultations as well in the future. So the technology is there, and this will enable us to invite interpreters into video guided self-help, and it's something that we're looking into at the moment. So talking of video guided self-help, if we could move on to the next slide. So what is video guided self-help? Well, it's something that we're now going to be offering, or we're now already offering in place of face-to-face sessions. Essentially what it is, it's offering clients treatment using video calling or webcam. So to help explain it, sometimes I use buzzwords like FaceTime or Skype. So it's basically being able to talk and see clients on at the same time through our computer screens, very much simulating face-to-face treatment. With video guided self-help, the treatment format has remained the same from face-to-face guided self-help. So it's still 30 minutes treatment sessions, working through the client, with the client through CBT-based techniques, but using video conferencing software to enable us to do that through our computers rather than, say, using telephone or traditional face-to-face. There was a lot of video conferencing programs out there at the moment. We went, as a service, went for Microsoft Teams, as we found it was a good balance between the functionality but also maintaining confidentiality as well, but there is a lot out there. I'm going to be talking about Teams as that's what we've kind of used for our service. Through using Teams, we're able to book clients both into the digital sessions and able to facilitate sessions through Teams as well. The way that this works is that after their initial assessment, we'll contact the client for an initial consult just to develop our understanding of their main problem, how we can support them in treatment, looking at maybe what CBT-based techniques we can use. And we also use this call to determine if the client is able to and has the technology for video guided self-help. If they don't, that's fine, we'll continue offering them treatment via the telephone. If they do, however, we can then offer them video guided self-help. But as always, patient choice is at the heart of what we do in IAPS. So as clinicians, we want to make sure that we're providing patients with the relevant information about what video guided self-help is, how it works, enabling them to make that informed decision for themselves about whether this is a treatment option that they'd like to access. So really making sure kind of patient choice is leading what we do. So if I could go to the next slide, please. So part of being able to deliver a new kind of mode of treatment is the training side of it. So making sure there's adequate training and supervision in place to support clinicians in being able to offer it. As such, we developed a guide for staff on how to use Microsoft Teams to book clients into the sessions and facilitate sessions one-to-one, which I believe we're going to share and disseminate to everyone attending today's webinar. So I'd just like to open the document. Already opened, lovely. So due to time constraints, I'm not going to go into the document in too much detail. I'm just going to kind of very briefly cover what it looks at. But the good document basically just covers on how to install Teams, how to book clients into the treatment session through Teams, how to join the treatment session at the time of the appointment, and also how to use features of Teams during the appointment, such as virtual background. So for example, the background I've got right now, completely virtual, not real. So that's a benefit of using video conferencing software, is you can kind of choose what you want your background to be, which kind of helps on the clinician side of things, where you might be concerned about working from home can maybe feel a bit invasive if it's face-to-face and the client can see, but if you've got a virtual background, that helps. And another feature which we've been, I've covered in that guide, is screen sharing. So being able to share your screen with the client, and what this enables you to do, a little bit like where in face-to-face you'd hand the guide, the client, the patient guide to work through in the session. Screen sharing just allows you to do that kind of virtually, so they can see what you're wanting to share on your screen. So maybe whatever treatment session materials you're going through at the time. But not everyone reads the user guide, as informative as it can be. So what we did on the digital team is we also offered digital drop-ins throughout the week, which clinicians could put themselves into with someone from the digital team to have some light touch support and training. On top of this, we offered constant email support, and we did also run digital training sessions on how to facilitate video guided self-help, which we did also record as well, so the clinicians could watch back at any time. So kind of offering a few different ways in terms of training for the staff to access that. And if I could go to the next slide, please. But training, thank you. So training and staff is only kind of like half the equation. Now we also want to make sure that our patients know how to use it as well. So to this end, we developed a guide for patients on how to access the video guided self-help. If we could briefly open this document, would be lovely. So just very briefly to go through this, the guide just covers on, for the patient side, how to install Teams on their device. It isn't mandatory to actually download the program. You can access it through a web browser, but we just tend to find that using the program makes it a little bit more reliable. It then also talks about how to access the video guided self-help at the time of the session, so how to use the link to go into this digital session. And it also talks about how they receive a confirmation email before each session with a link to access it, and instructions and the appointment information as well. So we've tried to make it simple and user-friendly as possible for the patient to be able to access this form of treatment. If we could go to the next slide. So finally, just some top tips and kind of advantages we've found through using and setting up video guided self-help. First one, probably one of the most important ones as well, is it is important to work safely. So what we've noticed with working with clients from their home is that more emotional disclosure can arise. So it's important to be able to stay with that and work with that emotion during the session. As PWPs also really utilise supervision as well, because you may be finding a few more things coming from treatment that perhaps you wouldn't have found before as much. And kind of adaptations wise, also making sure that you work through things more slowly. Sometimes in video guided self-help, it can be, especially with clients who maybe have more technological limitations. I'd say another tip would be to consider making the most of the digital working by using all the functions that are available to you to encourage engagement. So I mentioned the screen share earlier on for visual aids, but what we found is the two teams have been able to live edit documents as well. So for example, if you take a hot cross bun, that's something you could live edit using video conferencing software with the client, so kind of really increasing engagement through that. Another benefit we've found with video calls is it does mean you get some of the same benefits as face-to-face treatment. You can read facial expressions, body language. This is very helpful in getting a fuller picture of the client's experience. And it also gives you an opportunity as the clinician to be able to effectively convey empathy. But in terms of specific adaptation I talk about here is remembering to keep eye contact, which is a little bit different when working with kind of video guided self-help, because if I was to say, look at you on the screen, I'm not necessarily maintaining eye contact. For me to maintain eye contact, I have to look at the webcam directly, which I'm doing now. So apologies if that makes anyone feel uncomfortable, but that's how you maintain eye contact using webcam or using video consultations. That can be really important as well. In terms of some other advantages we found to it, we found that treatment can be adapted to those who were previously doing face-to-face treatment, but it can also be used for people who maybe were doing telephone treatment in the past. I guess it all depends on the patient and kind of patient choice there. We found it does support accessibility. So for example, people who have long-term health conditions or would have previously had to travel quite a long way to have a session, this kind of enables them to be able to have the sessions more remotely and from the comfort of their own home. Teams, like many video conferencing softwares, does have a help page within the program, which I'd kind of recommend for anyone when they first start using it. I'm sure many other video conferencing software have the same thing as well. I'd say the most important thing though, when starting to have a look at how to use video guided self-help, would be to practice this. So I found it really helpful to do dummy runs with a colleague on how it works, so that I was comfortable myself on how to use it before going live with the client. And finally, I'd just like to say staff training is really, really crucial. So making sure the training is accessible, if you can record it, doing different modes of delivery, one-to-one drop-ins with staff, allowing and also allowing changes to working schedules so that the PWPs have time to actually be trained up on how to work effectively remotely as well. So I'd say that's really important. But that's it for me. Hopefully that was somewhat informative and to give you a bit of a picture about how we've continued to offer one-to-one treatments remotely and offer this new video guided self-help. I'd now like to pass you over to my colleague Sarah Hawkins. She's a senior PWP Step 2 course leader in our service, and she's going to talk to you a little bit more about how we've also continued to deliver group treatment online and remotely. If you have any questions, as I'm sure was mentioned earlier on, feel free to type questions in the chat function. Thank you.
Good afternoon. Hopefully you can all see and hear me. I'm here just to talk a bit more about the digital psychoeducational courses. So these psychoeducational courses at Step 2, usually we would be delivering these across the community. And we've got two courses, a mood management course and a stress and anxiety management course. We have about 6 of these courses starting every month at Healthy Minds. So we knew it was a very important frontline intervention to keep on top of when we were faced with COVID restrictions, which is why we've put some work into adapting them and developing digital psychoeducational courses instead. We cover the same material that we would usually do, and it's a 6-week course, but we've thought about how to make these a live digital course, and we thought it was really important to keep these as live courses so that we can use the information in the room really and use clients' experiences and be able to share that in an appropriate way. So we're trying to make it as interactive as possible, and we use and invite clients to either type any questions or reflections they have, or to unmute their mics and share that information, because we find that with Step 2 courses, the real benefit from them is that normalizing effect of sharing common symptoms and feeling like you're not alone. So we really wanted to keep hold of that. We are also very aware of how to manage risk with our psychoeducational courses, and a bit like has been mentioned so far, what we ask clients to do is, instead of bringing a physical MDS questionnaire to each session, we're asking them to complete these via the online portal prior to sessions. That means the facilitators can scroll along and see what their PHQ-9 question 9 score is and arrange risk reviews as necessary. If we just go on to the next slide for me, please. This is another guide that we've developed when we were training staff members and clinicians. So a little bit like the guides Alex has already showed, this is a very thorough guide of how to logistically set up a digital group. If we scroll down a little bit for me, it's very, very thorough and step-by-step of how to create the appointment, how to then send that appointment to clients. And a bit like what Alex was saying, the training of clinicians is key in managing this as well. All our training has been recorded, and if anyone missed the training, they know where to find it as well. As it's such a new way of delivering courses, we also run course of supervision. We do that every 2 weeks, and that's a safe space for clinicians to bring any questions they had, but also to share knowledge of what's worked well. And we're very much encouraging sort of that learning experience. So if the clients found a particular way to make it more interactive that's worked well, to feed that back to the team and share that with the team as well. If we can just go on to the next slide again for me, please. We've just got an example here of a typical email we send to the clients when we're inviting them into the course. So this is this is when the course is about to start, so usually the day before the course is starting. So it's a standard structure of what to expect from the course, but you'll see as well in bold, you've got about being in a confidential space. Especially as people are running this from their own homes, it's thinking about how to make that space quiet and appropriate for treatment. And then on to the next page for me. So we found that there are certainly some advantages to running digital courses. It can be more accessible for people, and quite a lot of people are finding and feeding back that they feel more comfortable being in their own home environment. So a bit of a safer space to be in. The platform we're using with Microsoft Teams is a secure platform and safe and robust. And so far, the feedback we're getting is that it's a very positive experience and effective. However, we're also aware of considerations to make sure that it is a safe environment facilitated by our clinicians, making sure that it is stable with a good internet connection. And we'll also be thinking about how to adapt these going forward, and whether to have a bit more of a blended approach like Paul was talking about earlier, to maybe have certain videos, maybe a 4-minute video purely about physical symptoms of anxiety, for instance, and then bringing it back as a group and sharing that experience. So kind of mixing it up a bit so that we can kind of help with attention and engagement through those courses. And then the next slide's really nice as well. We've just got some of our recent feedback. So these are courses that have started about 3 weeks ago. The bubbles in blue are from clients themselves. So good pace of the session, nice to have a break in the middle. Someone saying that online video felt quite comfortable in their own home. And I thought a nice one was, thank you, I realise I'm not alone in this anymore. I know that I'll be able to learn how to cope in the future and develop strategies. In green, we've got feedback from our clinicians as well. So thinking about utilising different skill sets and how to develop that and how to make it as engaging as possible. So feedback that the chat function is a helpful way to keep it interactive as well. And then the final slide from me is just talking about how we're going to develop things further. This is new, so it's worth acknowledging that there might well be adaptations and changes that need to be made in the future. And I think it'll be really interesting as our first digital courses come to an end to compare feedback to a physical course over a digital course. We'll be doing that with client feedback as well as recovery rates or MDS outcomes, and reviewing that and thinking as a team how we can utilise this platform and treatment format as well. We're also thinking about what to do in the event of any staff sick leave. So thinking maybe it's worth having some backup sessions of pre-recorded sessions that we can use if we need to as well. So it's kind of rolling with this and figuring out sort of ways to improve things if needed as we go along and sharing that experience. So quite a short one from me, but any questions, feel free to leave any comments, and I'll hand over to my colleague Tanya.
Thank you, Sarah. Hopefully you can all see me and hear me okay now. Hi, my name's Tanya and I'm a CBT therapist and team lead from Healthy Minds. I'm also a lead on our older adults work stream, so that's what my first slide is going to be about. Access rates for older adults at the moment has decreased, and we can kind of try to think about reasons why this might be, and I think from my experience it might be a couple of reasons that we might kind of consider that this might be the reason for. So one might be that some older adults might feel that they don't want to burden the NHS, or might even be worried about accessing services due to infection. So I think it's really important that we consider this client group who might be particularly vulnerable at this time. When we're remote working, when we're trying to move to remote working, we're effectively going into somebody's home environment. So that's, I think, generally across the board really important to think about, and to think about how we ensure that we create a safe therapeutic environment when doing so. It's also really important to think about accessibility. So, for example, if you are recommending a website or sending information to an older adult, maybe the resources that you might be using, making sure that they are really clear and accessible for that person, thinking about their particular needs. It's also really important that we don't assume, but that we offer a variety of treatment methods, and again, thinking about the individual's needs. Some older adults might have access to a computer and might quite easily be able to use that computer, so it's important to not assume that they wouldn't, but also it might be worth considering that there is also that percentage of people who wouldn't be able to use a computer, and for those people, for example, it might be that telephone treatment would be a better option. It's also really important to consider practical and social needs, again across the board, but particularly we might make specific considerations for older adults. So, for example, it might be signposting to befriending services if isolation is particularly part of their main presenting problem. So there's just a few things really just to have a think about and consider when working with older adults. If we can go on to the next slide, please. So just overall thinking about specifically remote working with clients, These are just a few take-home messages really to consider before we go on to think about how we kind of support more of the PWPs in remote working. So I think first of all, it's really important that we actively promote IAP services, as it's important that people are aware that we're open and that we're accessible and still relevant, and that we don't kind of get pushed to one side as a service that might not be running anymore. I think it's really important and key that we're aware that everything is still working as usual, and there's just some of the adaptations that we've mentioned. It's also more important now, more so than ever, to offer a choice in treatment. There's a paper which is going to be sent round, which Paul has recommended, on a Manchester patient survey of phone calls, and it showed that a significant proportion of patients who completed telephone therapy and did well still said that if they were given the choice, they would have had a preference for face-to-face treatment. And I think particularly in lockdown, it's really important to think about what options people might want, and it might be that more people would have a preference for video calls. So I think at the moment, more than ever, it's really important that we continue to use our IAP model of being able to have that patient choice, have those options to choose from for treatment. And as mentioned by Sarah, we are still developing our remote working, and I think this is something that will be ongoing to come in the future. But we have also thought about supporting staff to work remotely, but it's not just about the staff. It's also about future considerations, might be about also how we support clients as well. So if there are those that might be less familiar with the technology that we're using, how we can support them with training them and offering them the information that they need to be able to access these options. Okay, next slide, please. So these are the objectives around supporting PWPs in working remotely. So how to work safely at home. So I'm going to go through some working from home guidance that we've created as part of Healthy Minds. Share some ideas for training and supporting PWPs to develop skills to deliver remotely. Show ways to provide accessible remote supervision and to give examples for supporting PWP wellbeing, which John is going to go on to talk about later. So next slide, please. So just a little bit of information and background around working from home effectively and safely. We have got a document here that we've created, which we can send around after. I'm not going to open it up now today because of the time, but it will be available to you in the future if you want it as an example. So actually, Healthy Minds were a service that were working on plans around home working way before COVID-19 changes happened. So we were already sort of developing this, and we just speeded up the process to develop this to make sure that it could happen quickly enough to make the changes as we needed to. So we've developed a working from home guide, which is the print screens that I've put at the bottom of this slide. And what that includes is it highlights kind of guidance and considerations that you need to take into account when working from home. So for example, making sure that you have the correct equipment and technology to be able to work from home, being up to date on the information, governance, training, having a safe, confidential space to be able to work from home. So all these things that are really key and important in order to be able to work effectively and safely from home. So what we then did is we have kind of particularly detailed guidance on this, and then the checklist, which is the bit that I put at the bottom, will then ask the clinician and the line manager to go through this checklist, check it off and sign it off before starting working from home. So we made sure that this had happened across all our staff before we began working from home. Okay, and that's something that you can kind of, as I said, take away and have a little look at. I think it's quite a helpful document for that process of making those adjustments to changing your way of working. Okay, next slide, please. Another thing that we did as part of our change to working remotely is thinking about how we do our team meetings. So previously at Healthy Minds, we had a monthly team meeting. Since remote working, we've now moved to doing a weekly live event. So this works quite similar to this webinar that we're doing right now, actually, in that the presenters are broadcast and give various service updates to share to the whole team, and the team can then ask questions in the chat function and we'll kind of respond to those as we go along. So we've had quite a few benefits really to doing meetings this way. So far we've found that the information can be really easily shared, and we use things like the sharing screen function to be able to show slides and bits of information that we might want to share. And also we make sure that we record every session. So then if there is anybody who isn't able to attend the meeting at that time, who might be on leave or have other things that mean they're not able to, they can watch it back later. And we publish that in one of our newsletters that we send out via email each week. So people can attend from any location, which obviously is a massive benefit, that it saves time and money. It's quite convenient for our staff. And also we kind of find that it's just helped the team to feel connected as well generally. So they've had that support and that catch up each week to keep in touch with what's been happening and to get all those updates. And overall the feedback's been really positive. People have actually said that they find this is a better way of doing the team meetings. So it's really nice to get that positive feedback from this change that we've recently made. Okay, next slide, please. And leading on from that, we've got our digital training. So Oxford Health Foundation Trust is a global digital exemplar, which means that we have an ongoing active programme of digital innovation, which has been running for a while now. And along with that, with the recent remote working changes, we've ensured that we have a strong training programme, as we appreciate that it's really important at this time that staff are given the training and the skills that they need to make the adjustments to how they're working. So we've provided that in lots of different ways. So one example is the digital drop-in sessions, which I know Alex mentioned earlier. So PWPs can chat with one of our digital experts to help them with any questions or to help them work through some of the processes. As you've also been given a taster of, we've also been developing quite detailed user guides so that you've got all the information that you need. If you kind of need to go back and remind yourself of how to do something, you've got that paper copy there to do that. And as well as that, we've also been doing lots of different types of training using digital teams. So we've tried to keep training really interactive and interesting. We use lots of features when we're doing our training, like using whiteboard and the chat function, separating into small groups, those kinds of things. And actually we found that we've been able to hold quite a few trainings since COVID-19, and we've held lots of trainings remotely, same as this sort of format. That's included things like training, a clinical skills training on coping with COVID, and a safeguarding training with our safeguarding nurses, and we've also done a screening assessment training quite recently as well, so that's been quite successful. Okay, next slide please. So just a little bit about our trainee PWPs. So our service at the moment actually has a new cohort of trainees just started this week, and that includes our usual standard university cohort of trainees, but also some trainees from our apprenticeship programme, which is new. We are supporting our trainees by remote working in lots of different ways, and some of these include the supervision from us and from the university. So again, we're using things like video and telephone to offer close supervision, and we're also providing some joint training. So there's been a lot of communication with like the university and the training providers to be able to connect together, offer some sort of joint lectures at times, and be able to meet and make sure that we're supporting staff jointly as they're training. We also ensure that training continues to be effective, engaging, so we're following exactly the same curriculum as it would previously when it wasn't done remotely, so ensuring that you're still getting all the benefits of the training as you would if you were doing it any other time. And as previously we suggested, sometimes it might mean that there is less opportunity, I suppose, for vicarious learning because you're not in that same environment of being around people and, you know, just being able to grab somebody nearby and ask them for some advice or have your peers around you for support. So we're making sure that there is opportunities for support and opportunities for training to sort of make up for that. So one example would be that in our recent induction and supervision, we've been using things like vignettes and examples, so to try to help people to think about some of the things that might come up and try to enhance their learning a little bit around the things that they might be missing. So that's some of the ways that we are supporting trainees. If you go on to the next slide, I'll talk a bit more about supervision. So now that we're working remotely, it's really important to us that our PWPs do feel supported. And as I mentioned, there are sometimes less opportunities for informal supervision, which means it's even more important to have those things scheduled in. So it's really important, I think, that first of all, it's communicated that PWPs are aware of how they can access that support and supervision. So, for example, in our service, we have a daily duty supervision that's available for if anything urgent comes up, and we make sure that we email out the details of that availability of the staff's details, their telephone number and their email addresses on the day, or either on the morning of or the night before, so that as soon as you're starting your working day, you know exactly who you can contact if you need somebody. We also are offering further capacity for supervision. So at the moment we offer virtual drop-in sessions so that if they need to discuss any of the assessments that we've been carrying out, they can just book themselves into one of those slots, and at that time the supervisor will contact them and they can discuss their case. We're also offering more support from line managers. So We are offering weekly check-ins, so along with their normal line management, they'll also be checking in each week to let their line managers know how they're getting on with the changes to their work plan and just generally how their well-being is at the moment. And usual case management and clinical skills supervision is happening as it is usually, but we've now moved to doing that on a video call or telephone. So I'm now going to hand over to John, who's going to continue talking about well-being in the team. Thank you.
Thank you very much, Tanya. And I have the pleasure of finishing off. Okay, so I'm going to talk a little bit about well-being. Obviously, crucial issue here is for us to think about the well-being of staff. We have a well-being team in the service already, and they've been very active during this period, working more remotely as well. So when we have our live event, we always have a well-being slot with it, but also we have well-being sways, which are special interactive newsletters that go out to everybody. And really kind of providing tips on staying well during lockdown, sharing successes, encouraging people to use some of the support services that have been developed for NHS staff, and remote team building activities, all of which can be really helpful to people. Next slide. And just showing another example of a way you might go about this. This is one that Paul's shared with us, is a program that he's been developing around resilience training. And I'm hoping that as we go forward, Paul's going to start offering this out across the Southwest. I think originally he's got some research funding to look into it, but it sounds a very interesting way to kind of build our resilience. Next slide. This is a method specifically we've been using both at Healthy Minds, but also more widely across Oxford Health. The Huddles model was originally developed by a psychologist in ITU settings for inpatient settings. We've adapted the model and made it a virtual model. And the advantages for us with that are we can really kind of gather people together in virtual huddles, focusing much more on well-being and togetherness. We have 5 huddles operating across Healthy Minds. They operate every day for 15 minutes. People come together with a facilitator, touch base, look at well-being issues. The huddles can have their own agendas. It's not set that they have to talk about work issues. They could talk about anything that's important to them. So next slide, please. Thinking a little bit about our well-being. COVID-19 is a very demanding time for all of us. It's stressful for our patients, but also we're having to take on lots of new ways of doing things and can be very stressful as well. And so just a few tips really that we're focusing on, kind of being kind to our patients and to ourselves, trying to think about connecting with our colleagues, with our family, with our friends, making sure that we're taking breaks, that we're putting rewards in and looking after both our physical and our mental well-being actively, and trying to discriminate between work and home life, you know, changing position, making sure you do something active at the end of the working day to break it out, change your clothes, anything to help you to kind of make that switch. Next slide. So what are our take-home messages around supporting PWPs? First of all, ensure they have a safe working environment with the right equipment, IT, etc. Make sure you provide an active program of ongoing training to enhance digital competencies and adapting their practice for working remotely. Ensure that there's accessible and regular supervision and a strong focus on PWP wellbeing with an active, multifaceted wellbeing program. So that is the end of our slides. Thank you very much for listening through. I know it's a lot of information. but we'll take a few questions now, I think. Thank you very much.
Okay. Sorry, bear with me.
Hi, it's Ursula from the national team. Just while Sam is getting those questions ready, there's a couple of themes that have come through on the questions that I just wanted to put forward because we've got very limited time. The first one is a lot around staff wellbeing at the moment, and PWP is particularly working exclusively from a screen or from a telephone, and feeling under pressure. I think that's sort of part and parcel of the anxiety that the whole nation is feeling at the moment. But is there anything you could say from your service, John, around particularly what services might need to consider at this time by way of sort of being a bit more considerate of staff who may have children and maybe parent, teacher, as well as trying to work, and the demands on staff at the moment?
Yeah, absolutely. And of course, I brought the staff wellbeing last in the talk because it's something I really wanted people to be focusing on at the end, that recency effect. So some of the questions may have come before we got to that bit. In addition to the areas we covered, so it's really helpful for you to point out that we've also been working with staff individually on kind of thinking about work flexibility, how their hours could be adjusted, for those staff who can't work for any reason, how we support them as well. And it's quite a crucial issue really, to make sure that you're treating everybody individually, but also have a range of different offers for people that meet their needs for support. One other thing we did as well was we also, during the initial phase, did reduce everybody's activity plans in order to give people time to move home, adjust, take on new ways of working, and sort of manage the kind of pressures and the things of learning a completely new way of doing things, just in the same way we would with trainees, that we don't expect trainees to do the same sort of caseload because they're learning a whole lot of new things. And that's what we're asking our staff to do as well.
Thanks, John. That's really helpful. Sam, are there any other questions?
I'm having a bit of a technical issue here. It's only scrolling back 10 minutes. Are you able to scroll back any further? Because they have been answered by Alexander. I'm not sure.
Yeah, so
I'll apologies for that. Yeah,
I'll pick up on some of the questions that have been asked. There were some questions that I think are relevant for Paul around the training. So is there any plan to add or alter the training to include the likelihood that many people will be having experiences of illness or bereavement? So focusing treatment around bereavement and PWPs knowing how to do this. There were also a couple of questions on training around recording clinical hours and being able to send recordings to university. So I wonder if you could just respond to that, Paul.
Okay, the issue around grieving, I think, is a really interesting one. And we would have to go back to the evidence base to see where that would be best addressed in terms of which workforce would be best suited, which would be the best interventions to take forward. So I think that really is a discussion for the national team to think about taking that one forward. What was the other question, Ursula?
The other question was around, you mentioned recordings for PWPs during the training, and I think some questions have been asked around how possible that is and what recordings you're referring to.
Right, the curriculum was revised back in 2015, I think, by UCL. And one of the revisions for competency assessment 2 was the requirement for that to be based on a live recording of a patient session, whether that was through some video or whether that was a telephone tape session. So that's actually been a requirement of the national curriculum for at least 5 years. So rather than it being a simulation, it's a recorded patient session. It gets, different services have different information governance requirements, but it gets taken to the it gets lifted or sent to the university. They then use competency assessment measures on it, and then it's the same as the old competency 2. It should be a live recording.
That's lovely. Thank you, Paul.
Ursula, could I say something about bereavement?
Yeah.
Yeah, thank you. It's a very important issue. Certainly in our local area, we've been working really closely with a number of the bereavement charities and third sector organisations in the last few weeks to really kind of think through together what our local response should be and how we can provide all the different skills that we have available locally to match those to the needs of the population as well, so that we're not kind of, you know, it's willy-nilly, somebody turns up one place and gets one thing or another, but actually us working closely together. And I would encourage people to do that. The second thing is that one of the things I discovered through that was that crews were making a number of national offers, one of which looked really interesting to me, which was kind of some basic bereavement awareness training groups that they were offering remotely for people. I think that's across the country, which was just a short session that might be of interest to IEP staff who haven't had any experience on that, around some of the basic issues around bereavement.
That's lovely. Thank you, John. And I think it's probably worth just saying that I'm expecting to have a conversation with the National Clinical Director of Crews this week around how IAP services and crews can work together, and hopefully some information will filter down as a result of that. Just time for one last question and ask, really, if that's possible. So there was a question from somebody around whether you have any advice for effectively working with patients who don't have computer, smartphone access when you can't post materials due to home working. So that's the question, and a lot of people have asked if it would be possible for you to share all of the materials you've talked about today, both the group materials, the MS Teams guidance, and all of the things that you've talked about. And if you're happy to do that, then we as a national team can share those.
Yep, absolutely. So I want to just also acknowledge that most of our guidance and our videos and everything we have done jointly together as a trust across our 2 IEP services, Talking Space Plus in Oxford as well. And yeah, I think we would all want to make sure that people had available, which is part of the reason we put them in as examples that you could borrow from, take things from as well. Yes, in terms of other ways we've done things, certainly we have moved to emailing people things where we can email people things, but as you say, that isn't always possible. And there are some things that what we've had to do for the remote workers is that who haven't got an email address for somebody to go to, we do have a situation where we have one person working who comes in and can do printouts and post things out to people as well. So we maintain the social distancing, but we have access for that admin person to be able to print stuff out. But as much as possible, we're sending things electronically, and as I say, all our GP letters and things going out via document. So it's really reduced the flow of stuff having to be posted.
That's brilliant. Thank you, John. Can I just say a huge thank you to you all for the time that you've taken to produce the webinar today, and also for giving us your time so freely and your resources so freely as well. So thank you all very much. We are just about to close. We won't be able to answer any further questions individually, I'm afraid, but please do share the information that you've received today, and also a plea to services. Please talk to your services. A lot of the questions that were coming up are around internal service protocols and service delivery. Please speak to your line managers, supervisors, clinical leads if there are services that work in a way that you feel are very challenging at the moment, and try and have those conversations internally. From a national team perspective, it's very difficult for us to provide that governance across the country. That needs to come locally. So thank you to everybody, and we'll say goodbye for this week.